So you might be wondering what eggs have to do with improving treatments for experiences of negative symptoms in psychosis. And to be completely honest, they're just for illustrative purposes. But if we could take this egg in the bottom left of this carton here, that's a little bit isolated from the others, and personify it for a minute, we can maybe relate it to someone we've seen on social media or someone that we know personally who we know not to be as engaged in things they used to enjoy, and perhaps even enjoying those things a little bit less than they used to when they do take part in them, or perhaps a little bit less motivated for other things in life more generally. And in the context of psychosis, we would group these things together and label them as negative symptoms. But beyond the 1% of people who experience psychosis, these principles I'm going to talk about probably go a bit more broadly than that. So when we think about these difficulties and how we as psychologists can help, we think immediately about some of the public health campaigns that exist. Let's Talk, Time to Talk, all of which that engage people who are struggling to come out and talk about things that they find really difficult. But when your difficulty is engaging with people in the first place, we really need to look at how psychological therapies can first help people to do that before we move on to those more traditional talking therapies that we might think of. So one of the capacities that we arguably need to be able to do this is this capacity called reflection, which this little egg is doing up here in the corner. And when we think about reflection, we can think about different domains in which we understand things. So how we understand ourselves, how we understand others, and how we take those meanings and bring them together to make a cohesive understanding of the world. And if we are not able to do that, my research shows, then we're actually much more likely to have higher levels of these negative symptoms. And we group those kind of capacities I've spoke about together, and we call them metacognition. So in response to those findings, we looked at whether a metacognitively oriented therapy, quite hard to say, can work for people who experience negative symptoms in inpatient settings. So we asked people who were inpatients to take part in 26 weeks of therapy. And to be honest, I can't actually tell you anything yet about how that therapy works, because what I can tell you about is the massive difficulty that I've had actually getting these people to engage with this therapy in the first place. And when you can imagine that the difficulty is speaking to someone in a one-to-one setting, asking people to do that for 26 weeks maybe makes it quite understandable that that's an issue. So we're beginning to think that maybe my PhD shouldn't have been focused on how do we treat negative symptoms, but rather how do we engage people who experience negative symptoms in treatment. And that's what my final study, which is looking at virtual reality, is going to test. Is that modality that's maybe safer and more controllable, more acceptable as a basis for treatment?